All right, I'm going to attempt to do a whirlwind tour of the cerebellum. We're really going to focus very superficially on the chapter. We're not going to go into detail about anatomy or the different structures or the function of those different structures. Basically, we want to know what are the major roles of the cerebellum, and it can be summed up in a sentence or two. We're going to look at clinical signs that can be indicative of cerebellar dysfunction, dysmetria, dysdiadochokinesia, which is a great word, action tremor, ataxia, dysarthria, and nystagmus. And we're going to talk about clinical testing that's done to distinguish between sensory and cerebellar ataxia. So, ataxia is incoordination, and it can be caused by a peripheral issue, a sensory issue, or it can be caused by cerebellar dysfunction. And how do we tell the difference? There's an easy test that we can tell. So, the cerebellum, its basic job is it adjusts posture and coordinates movements. To achieve smooth movements, the cerebellum integrates information from the frontal lobes about intended movements with sensory information. There are no direct connections between the cerebellum and the motor neurons. It exerts all of its influence through the cerebrum. All cerebellar functions are non-conscious. We don't know about it, but it's going on in the background. And cerebellum, the name really means little brain. So it's our little brain back there underneath the occipital lobe, tucked up behind the brain stem. So the cerebellum, like I said, has no direct connections between the cerebellum and the lower motor neurons. The cerebellum influences movement via synapses with upper motor neuron cell bodies in the motor cortex and the premotor cortex and the brain stem. So if you have damage to the cerebellum, even severe damage, it doesn't interfere with sensory perception or muscle strength. The damage results in impaired coordination and postural control. So there are distinctive signs that you'll see with cerebellar dysfunction, and we'll talk about those. But even though the cerebellum is really doing a lot of stuff, it doesn't have a direct effect on the motor output. So the cerebellum is inferior to the occipital lobe and posterior to the brainstem. There are two cerebellar hemispheres, just like there are two cerebral hemispheres, attached to the posterior brain by three large bundles of axons that are called the cerebellar peduncles, which is another great word. The cerebellum has some good words associated with it. Those cerebellar peduncles, they show up on imaging as just tons of axons, myelinated axons, because lots of information is going back and forth to the cerebellum all the time to check actions and say compare intended actions with what really happened and make corrections through the motor neurons. So the cerebellum is a busy. Lots of information. Human movements can be categorized into three broad classes: equilibrium, gross movement of the limbs, and fine distal voluntary movements. There are different areas of the cerebellum, and I don't expect you to know the individual areas, but that are responsible for those three broad classes. So each of the classes of movement can be illustrated by considering the cerebellar contributions that occur when a person reaches for a book on a high shelf. So it requires equilibrium. You have to stay balanced because you look up and you tilt your head back and you get vestibular input. And you have to lift your arm up, so that's gross movement. And then you have to have fine voluntary distal movement to grab the book. So the cerebellum is working for us all the time. Thank your cerebellum if you haven't already today. It also has lots of effects with regard to cognitive, emotional, and social functions. So the cerebellum is involved in goal-directed behavior. Like we said, the anterior frontal lobe is involved in goal-directed behavior, language optimization, and visuospatial function. The emotional functions of the cerebellum include processing, storage, and retrieval of emotional memories and regulating emotional responses, and optimizing social behavior, which I think is pretty interesting. So, like how we interact with the other humans. The red nucleus in the midbrain is part of a circuit that optimizes complex motor, cognitive, and emotional functions. So it's this little area, they call it the red nucleus. So there are lots of cool structures in the brain that are named by how they look, and that's one of them. There's the locus ceruleus, which means blue part, blue location or something, and there's the red nucleus. So um, it's the cerebellum is not just involved with movement, but it's also involved with lots of other cool stuff. So the signs, we see motor signs with cerebellar dysfunction. They the signs of motor dysfunction involve abnormal motor execution that doesn't change with or without the use of vision. So your ataxia, it doesn't matter if you have your eyes open or eyes closed. With sensory ataxia, it does matter. It's going to be worse with your eyes closed. So ataxia is a movement disorder that's common to all lesions of the cerebellum. Lesions involving the vestibular part of the cerebellum cause nystagmus, which is in pathological eye movement, unsteadiness, and difficulty maintaining sitting and standing balance. And we have the two lobes of the cerebellum, and they do cross over to the other side of the body, or they don't cross over, sorry. Like the cerebrum, they do cross over, but cerebellar lesions cause ipsilateral impairment, so the same side. So kind of interesting. Minor, but interesting. So spinocerebellar lesions can result in limb ataxia with the following manifestations. So dysdiadochokinesia is the inability to rapidly alternate movements, and it's often tested by having someone pronate and supinate their forearms or tap feet alternately. So doing rapidly alternating movements, that's something that we can normally do, but when you have cerebellar dysfunction, you can't do that, and it's called dysdiadochokinesia. Dysmetria is the inability to accurately move an intended distance. So the picture here is showing a test for dysmetria where you have the person touch their nose and then touch your finger. Touch their nose, touch your finger, something like that. And so normally we can just do it, but with dysmetria, you can't quite move that intended distance. It's like you reach out for your cup of coffee and you miss. Action tremor is the shaking of a limb during voluntary movement. So that's common with cerebellar dysfunction and action tremor. There's also resting tremor, and that is more common with basal ganglia dysfunction. The action tremor with cerebellar dysfunction tends to get worse at the far end of the movement, the finishing part of the movement. So in compensation for limb ataxia, you often get movement decomposition, where you can do part of a movement, but you can't do the whole movement. Dysarthria is discoordination of the speech muscles. So you still have all your speech parts in the cerebellum that we talked about are working, but the speech muscles are discoordinated. So they either come out at dysarthria, flaccid dysarthria comes out as soft, breathy speech and slurred, and spastic dysarthria comes out as harsh, uneven speech, but it's discoordination of the speech muscles. Gait ataxia is a wide-based staggering gait. Spinocerebellar lesions also interfere with coordination of fine finger movements, like the ability to play a musical instrument or fasten buttons or pick up small objects or type on a keyboard. I don't know, maybe if you type with one finger, it'll work. I don't think so, but just those fine finger movements. So not all ataxia is caused by cerebellar lesions. You can have sensory ataxia as well. So your movements are discoordinated because of some disconnect in the sensory system. So to differentiate between somatosensory and cerebellar ataxia, movement coordination should be compared with eyes open and eyes closed. So cerebellar lesions are going to cause ataxia regardless of the use of vision. And in cerebellar ataxia, your vibration sense, your passive proprioception, and your Achilles deep tendon reflexes are all intact. They're all normal. With sensory ataxia, you're going to have a change in the ataxia, whether or not you're using vision. When you're using vision, um, you don't have as much ataxia, and you take away the vision and you have more. Um, with and you probably have impaired vibration sense, passive proprioception, and Achilles deep tendon reflexes. So the test that's used to distinguish between sensory and cerebellar ataxia is called the Romberg test. So it measures the ability to use proprioceptive information for standing balance, and it's a super easy test, and you do it in the clinic all the time. Or, you probably will. So the patient stands with their feet together, eyes open for 30 seconds, and then eyes closed for 30 seconds. Arms are supposed to be crossed over the chest. Um, so eyes open for 30 seconds, eyes closed for 30 seconds. The score is pass or fail. If you lose your balance, you failed. That's a positive test. So, also, if you move your arms to maintain your balance, so you have your arms crossed and you reach out to grab something to maintain your balance, or open your eyes during the eyes closed part, or if you start to fall, or if you require assistance, then all of those are fail criteria, and it's a positive test. So when you have a positive Romberg test, it suggests that your ataxia is sensory in nature, because you didn't have problems the eyes closed, with the eyes open, but then you did have problems with the eyes closed. So with cerebellar ataxia, it doesn't matter whether your eyes are open or closed. You probably can't do either one of them. So that's the Romberg test. So in people with cerebellar limb ataxia, they can't stand with their feet together with or without vision, even though they have those normal sensory testing. People with sensory ataxia can usually stand steadily with their feet together with their eyes open for 30 seconds, but then their balance is impaired when their eyes are closed. So, and conscious proprioception and vibratory sense are impaired, and ankle reflexes are decreased or absent. So that tells you that it's sensory. You fail the sensory tests, um, and you fail the eyes closed part. With cerebellar ataxia, even with vision, you can't balance, even though you have normal sensory testing. So, cerebral cognitive affective syndrome includes visuospatial impairments, so deficits in copying and recalling visual images. So if I drew we did that little activity where you had to draw, it was a communication activity, but if I just had a simple drawing and said, here, reproduce that, doesn't work. People have difficulty recalling visual images and judging distances, and that's your dysmetria too. In language, you can have deficits of word finding, brief responses, long latency before speaking, so it just takes a while to process. Inability to understand metaphors or ambiguity. So people need specific language goals. There can be problems, deficits in planning and organizing for goal-directed functions, and a flat affect, meaning they don't display nonverbal emotions, and impulsiveness or disinhibited behavior. So, cerebral cognitive affective syndrome can affect a lot of different things. In some developmental disorders, like autism spectrum disorders and ADHD, they show decreased volume of both cerebellar and the posterior vermis of the cerebellum. So that's interesting. And in developmental dyslexia, there are abnormalities in anterior and posterior cerebellar hemispheres. So it shows you kind of the wide range of activities that the cerebellum controls. So the acquired disorders that most commonly affect the cerebellum include multiple sclerosis, stroke, tumor, alcoholic degeneration, because and what we consider to be an ataxic gait It's also like the 12 shot gait. I don't know about 12 shots, but it looks like you've been drinking. Wide, staggering gait is an ataxic gait. Compression of because alcohol affects the cerebellum, and so that's why we perceive it as that. Compression of the inferior brainstem and cerebellum in the foramen magnum, which can happen in an Arnold-Chiari malformation, which is a developmental issue. Inherited degenerative disorders that affect the cerebellum include spinocerebellar ataxia and multiple system atrophy. The prevalence of spinocerebellar ataxia is approximately 6 per 100,000 people. I've worked with some people with spinocerebellar ataxia in the clinic, and aquatic therapy is great for spinocerebellar ataxia. And everybody that I've worked with has had good improvements, so I like that. It's lovely. So the cerebellum is just densely packed with neurons, even more so than the cerebrum. It receives way more input than it sends. The processing is all non-conscious. It coordinates movement and postural control, optimizes emotional, social, and cognitive functions, and cerebellar damage is confirmed by comparing motor performance with eyes open and eyes closed. So, if there's a difference with the eyes closed, it's sensory. If there's no difference between eyes open and eyes closed, it's cerebellar. So the main function of the cerebellum is to um, compare the actual movement with intended movement and make corrections through the motor cortex. And all those other functions too, but for the main motor effect is to compare actual with intended and make corrections. So if you can't make corrections, it results in discoordination. Hopefully that makes sense.